I'm sorry, Dr. Varsha, I just got logged out, or there was some problem with the entire Zoom meeting only.
Okay. Yeah. So, shall we start then?
Yeah.
Okay.
Are my slides visible now?
Yes.
Okay. All right. So, very good morning to all of you. And thank you, Dr. Varsha, for that kind introduction, and also for that special line of young rheumatologists. Thank you. And of course, thank you, MRA, for involving me in this program. And teaching has always been a passion. I enjoy it, and I have been doing it since the residency days. And I think it's a very good method of self-learning as well. So with this, I start with my talk for today. The topic is the first session of rheumatoid arthritis, which is focusing on the pathogenesis, the clinical manifestations, the classification criteria, and diagnosis. And I must say right at the beginning that this is a clinical talk, and it's not loaded with information, but it's loaded with a lot of clinical pictures. And I would want the students, the postgraduate students, to have this clinical picture in mind, because at 30 to 45 minute snapshot, it gives you the entire spectrum of rheumatoid arthritis, which gradually we keep seeing over a period of time. We will look at the extra articular and the joint manifestations. The laboratory and radiological features I will not be covering in details, because I've been told now it's part of the session 2. So I'll just touch upon it, and then we will close up with the classification criteria and diagnosis. So we will keep it completely case-based. I'm not sure if there is going to be an interaction voice-based, but I'm happy if there are some textbook-based questions which can be put, and then at the end we can take one after the other. So let's start with the first case. I recently saw this lady who came to my clinic, 30-year-old with multiple joint pain since 3 months, delivered about 3 months back, and then gradually started developing this. And on examination, I found synovitis at multiple joints, and on investigations, a rheumatoid factor and anti-CCP was positive. And always the first question should be an easy question, I believe, to set up the tone. And therefore, the question is, what is the diagnosis here? And which is very obvious, given the clinical findings, examination finding, and the lab reports, that it is rheumatoid arthritis. And then the next question that the patient asked me is that, sir, what is it? And why did I develop this? And what went wrong with my joints? And that's how in the clinic now, from the simple question, the question level keeps increasing, and this is the patient asking you. And the first question to be answered is, then what is it? And we look at rheumatoid arthritis, we know that it's a systemic autoimmune disease. It's inflammatory, it's chronic. The main target of involvement are joints, particularly the synovial. So it comes with synovial inflammation, and it erodes the joints, therefore it is erosive. It is a symmetrical pattern arthritis, as you can see on the picture on the side. And it also has a tendency to go beyond the joints, and that's why sometimes it's called the rheumatoid disease and not just rheumatoid arthritis. What it does is it damages the cartilage and the bony elements of the joint, and this gives rise to the deformities and the difficulty in performing even simple activities of daily living. Patients struggle with holding a toothbrush, or even doing very simple activities of daily living. So a very quick knowledge about the disease that we are talking. It's important to know how commonly are we going to see in practice. It's about 0.5 to 1% of the population which is affected. And even in India, the prevalence is about 0.5 to 0.75, so which is huge given our population. This is a very huge number, and it is the most common cause of inflammatory arthritis that we come across in rheumatology practice also, 2 to 3 times more common in females. And the peak age of onset is around third to fifth decade. Causes significant morbidity. As you can see, the amount of joint damage and the difficulty and the work disability that it brings in just 2 to 3 years. And it's not just the morbidity, it's also the element of mortality, which increases about 2 to 3 times in patients who have rheumatoid arthritis with a shortened life expectancy. So often, of course, I go back to my MD days also, and when you are reading Harrison and you come across this part of pathogenesis of, say, any disease, you sort of want to skip through it or leave it for the later part and jump to the clinical manifestation and try and see. I don't know if it still happens, but what we realized later on is that this is probably the most important part, because if you understand the pathogenesis, you understand the questions of why it is happening, what went wrong, what is happening at the joints. And then you also understand the clinical manifestations. And then you go on to have the understanding of the therapeutic targets, why such a drug is being used in this illness. And now with the targeted therapies, it's all the more important to know about the pathogenesis. So this is common to most of the autoimmune disease. You have a genetic predisposition, an environmental trigger, and then it leads to an immune dysregulation. And this is a complex interaction that happens. So this slide shows you that the gene factors, there is susceptibility genes like the HLA-DR4, which is an MHC class 2 gene. Then there are some non-MHC class 2 gene, like if you have, you can see there on the top, the PTP22, which is the protein tyrosine phosphatase. And with the gene factors, there are some environmental triggers. So you can look at periodontal infection, gut dysbiosis, the P. gingivalis, the Prevotella, other infections like chikungunya, Epstein-Barr virus, parvovirus. These are also known to be potential triggers. And of course, the most important and most well-studied trigger for rheumatoid arthritis is smoking. So we have the gene, we have the environmental factor here. And now what is the best understanding in rheumatoid arthritis is the citrullination of proteins. And this happens through an enzyme, which you can see here, peptidyl arginine deaminases. And the target proteins get citrulinated. This citrulinated protein then becomes the captures for the antigen presenting cells. And these antigen presenting cells then interact with the T cell and B cell, which gives rise to the further cascade of inflammation. So just to keep it very simple, the genes, the trigger factors, and then this citrullination, and then comes the role of the T and the B cells. And then we move a next step forward, and we see that the interaction between the T cell and the B cell gives rise to cytokines. So you can see the TNF alpha, IL-6, IL-1, the rank ligand, and these will have different manifestations. So the B cell are responsible for the autoantibody formation. And then we have the osteoclast, which gives rise to the bone erosion. But the most important cell is in the joint, the synoviocytes, where the synovial fibroblast, there is inflammation. So we move on to the next thing. This is an important slide because there's so much happening in form of the treatment that the pathogenesis basis has to be known, that most of the cytokines are acting on the cell via the JAK-STAT pathway. And that leads to the transcription of the proteins. And then at the level of joints, what happens is the single simple layer of synovial membrane, which you can see here. I'm sure in the previous talk, the joint anatomy has been discussed, but just to show you here, the synovial membrane, which is got in an arthritic joint, inflamed, swollen, and then you can see that the bone is being eroded, the cartilage has got thinned out. So this is what happens, and that's what gives rise to the erosion. And this synovial proliferation is almost like a tumor-like growth called pannus. And this pannus is what destroys the various elements of the joints. So this is just to give you a pictorial view of how one can look at the pannus, look at the synovial inflammation and the proliferation that is happening. And this is destroying the cartilage and the various elements of the joints. So I think this much should be enough to know as far as the pathogenesis is concerned. Just to repeat, genetic factors, environmental triggers, citrination of proteins, antigen presenting cells, then the interaction of B cell and T cell, the cytokines, JAK-STAT pathway. Then there are the macrophages, the synovial fibroblasts, release of enzymes like matrix metalloproteinase, and then the pannus formation and the damage happening at the level of the joints. So with this, we move on to the clinical aspect of it. So let's have another case here, a 45-year-old lady who presents with small joints of hands and feet being painful, swollen, and with morning stiffness since 1 year. And on examination, there is an MCP, metacarpophalangeal joint, wrist, elbow joint involvement. And looking at the spectrum, and again, believing that this was covered in the last talk, which of the following joints would you think would be usually spared in RA? So you can give it a thought, you can put the answer there, you can answer, or obviously if you know it, we look at the clinical spectrum of inflammatory arthritis, and then I'm sure the answer will be very obvious. So we are looking at the articular spectrum. The joint manifested are the PIP joints, the MCP joints, and the wrist joints, the hand joints, the elbow and the shoulder, the knees, ankles, and the metatarsophalangeal joints, the midfoot joints, the cervical spine, not very commonly involved, but the atlantoaxial region is what can be involved. The temporomandibular joint and the cricoarytenoid joint are just to remember that they can be involved, but they are not very common manifestations which we see in clinical practice. What is not involved is equally important because this helps you in making the differentials. So the DIP is spared, the dorsolumbar spine is not involved, the sacroiliac joint is spared. The hip joint is a very unusual manifestation. You think of many other illnesses before you label this for rheumatoid. And most importantly, the pattern is symmetrical. So that answers our previous question that the DIP joint is what is spared. And this, I think, is a very important slide because this helps you in making a clinical diagnosis and excluding some of the differentials which are joint-based. So if you look at this slide, you can see that this is an early rheumatoid arthritis. And if you want, I would want you to focus on the swelling at the metacarpophalangeal joints, the interphalangeal joints, the wrist joint. You can see, of course, the left wrist joint is quite swollen. And this is the fusiform swelling, which we are seeing at this joint. Now, this is where we need to pick up the rheumatoid arthritis and not where we are used to seeing the deforming stages of the rheumatoid. So I think we can try and spend about 5 minutes because this is a very important part of the examination findings. And this is something which gets missed and we don't often get it in books. Of course, we do it in our clinics. And so if I want you to focus on this video for the next 5 minutes. So if you can see, this is a clinical examination being shown and the washing of hands, asking the patient for his consent before examination, positioning the patient properly. They're all important part of examining the hands. And so we inspect the joints. We look for any form of deformities that are very obviously seen in the joints. The nails are very important for the differential. We're not talking from the rheumatoid point of view here. So once you have had a look at the dorsal aspect, then look at the palmar aspect of the patient, and you can look some of these findings there, tenosynovitis, and then the elbow. And then this is a very important place where you look for nodules in rheumatoid arthritis patient, and we'll come to that in some time. So patients with rheumatoid often also, because of the wrist swelling, develop carpal tunnel syndrome, which results from the compression of the median nerve. And therefore, it's important to look at the musculature there. So this is the MCP squeeze. This is very sensitive in the early phases of rheumatoid, where even the swelling is not very visible. And one of the earliest clinical signs that one can pick up in patients with early rheumatoid arthritis. Of course, this is for the evaluation of the neuro component of it. And this is why I put the video here. The way the joints of the hands are examined. It's a bimanual method. If you look at it, the MCP joints using both your thumbs, you can feel for that boggy synovial swelling. And then the PIP joints are examined like this. You squeeze from the side with the finger and the thumb, and then you feel for the synovium with the finger of the other joint or the thumb of the other joint. So this is what I just mentioned, the early RA, MCP, and MTP squeeze, the sensitive way of picking up. And then we look at the other components, the other joints, the knee there. If you can see the swelling at the knee, there is loss of that fossa, which can be still appreciated here, which is not seen in this area. And of course, at the elbow, you can appreciate the swelling there, and there's a subcutaneous nodule here. So then from early RA manifestations, let's look at somebody who comes with about 5 to 6 years of multiple joint pains and has not been very compliant with medication, and therefore the rheumatoid arthritis has actually progressed. And now we look at established rheumatoid arthritis, and you can definitely appreciate things much better than what it was being seen in the case of early rheumatoid arthritis. You can see the swelling very, very clearly visible here. The swelling at the wrist also very much visible. And these are some of the changes that happen at the feet, very important, often missed. So while we focus so much on the hand joint, remember, rheumatoid arthritis also quite dominantly affects the foot and is actually a very important cause of disability for the patients. You can look at the valgus deformity that is happening at the great toe, the callosities which result from the changes in the biomechanics of the foot, and then you can look at the hammer toe, which all is resulting from destruction of the joint elements, and the biomechanics changes and the pull of the extensor mechanism actually leads to the deformities. And look at the deformities at the knee. And here I am emphasizing that for osteoarthritis, which is degenerative age-related arthritis, where you often get the medial compartment involved, and therefore you get what is called as a varus deformity at the knee, the inward bending. In rheumatoid, many times the lateral compartment is involved, and therefore you get what is called as the valgus deformity at the knee. And therefore, once you see this in any patient, the thought process for an inflammatory arthritis should be high on the part. And then we have the cervical spine involvement, where the atlantoaxial region is what gets involved with the formation of a similar pannus, which you remember I showed you at the knee joint. And similar pannus gets formation at the atlantoaxial joint between the arch of the atlas and the odontoid process. And then gradually it can damage the element of the joint, which leads to the atlantoaxial subluxation and then dislocation, and then can lead to a compressive myelopathy. And the way to pick this up is on doing a flexion extension X-ray of the lateral view. As you can see the opening up here, and then the moment it goes into the extension view, there is hardly any space there. And technically, this should be more than 3 millimeters. And if it is less than that, then it's suggestive of an atlantoaxial involvement. And of course, with the advent of MRI, we can pick up the myelopathy and the pannus quite well. I'm not sure if you can appreciate, but this is the pannus there, and then there is the compression happening on the spinal cord, which is very visible here. So from the other joint manifestations, let's focus on the deformities of the hand joint. So somebody who's had rheumatoid arthritis for about 8 to 10 years now and has noticed deviation of the fingers, has difficulty performing activities of daily living, and there has been a delay in diagnosis or reaching the rheumatologist or a clinician, and DMARDs have not been initiated early. Now, this is what I would like you to see, that this is a natural progression of rheumatoid arthritis. If left untreated, it is going to damage the joint and lead to deformities. And of course, the treatment, whatever we do, is to try and inhibit this progression from happening. And so the natural history of rheumatoid arthritis from presentation to up to 5 years. And then, as you can see, with the deformities developing over 10 to 15 years, this may be variable in different patients, because you may have one patient with a very aggressive rheumatoid arthritis and they may develop the erosions and deformities very early. And you may also see patients of rheumatoid who are 10 years into their illness and not having any deformity. So that has to be respected. It's a heterogeneous disease with variable progression. But in most of the patients with an aggressive disease, this will be the natural history. So we read about this, we know, and then we also say that we don't see this often now because we have therapies and this is too late of rheumatoid arthritis. But remember, there are patients of different spectrum coming to us, and it is important to know about the deformities, because there are patients wherein the diagnosis gets established based on the deformities that you pick up. So we look at the ulnar deviation. You can see that there is a very classical sort of an ulnar deviation that happens at the MCP joint, which can be appreciated here. And then there is the Z deformity of the thumb that happens. And at the level of hands, you can see that there is this well-known boutonniere deformity and swan neck deformity, where we are seeing, say, for example, the boutonniere deformity. You can clearly see that there is flexion at the PIP joint and extension at the DIP, whereas for the swan neck deformity, we are seeing it's exactly the opposite way. At the PIP joint, there is actually a extension that has happened, and then there is a flexion at the DIP joint. So that's a difference. Both, remember, result from the extensor mechanism being overactive, because the cartilage elements and the tendon that gets ruptured leads to an imbalance between the forces, and that gives rise to the deformities. So this is just another overview to show you the ulnar deviation can be appreciated. So that's the radial side, the thumb side, that's the ulnar deviation. And that's, of course, the swan neck deformities. And from here onwards, I think, yeah, one more two slides, and then we move to the extra articular features. So you look at this 45-year-old lady who is rheumatoid arthritis in 6 years and wrist joint swelling. And then she suddenly presents to the clinic and says that I have difficulty lifting the right little and ring finger. And you ask for any sensory loss or any injuries, and there are nil loss of sensation. And this is the clinical picture. And one should keep this in mind. And this is the finger drop, which results from the rupture of extensor tendon of digitomeninei. And this is different from the subluxation, which happens in rheumatoid arthritis, which is also called the piano key movement that happens. So here, it's the subluxation of the ulnar styloid, whereas here, it's the rupture of the tendon, which leads to the finger drop. So having looked at the joints, I hope you're with me. And sometimes, this platform of webinars and online doesn't give you a feel of the audience with you. So I'm moving now from the joint manifestations to the extra-articular features. And we see them in about 40% of the patients. And mostly these patients are rheumatoid factor positive. So we look at a patient of rheumatoid arthritis of about 10 years duration who comes with, severe pain and redness at the eye and photophobia, which is, she complains of about 2 months duration. And then when you look at the eye, you look at this picture, which shows you that, I don't know if you can appreciate, but look at the cornea here. And this is a corneal melt, which is a sign of active RA-related vasculitis, which has actually perforated the cornea. So the other ocular manifestation, if you can see here, the redness in the eye, painless. This is episcleritis, the nodular scleritis, the progression of the scleritis, which causes thinning of the sclera, scleromalacia perforans. And here you can see the dryness of eyes with a ropey discharge. Important again to know is that uveitis is not a part of rheumatoid arthritis. So like we said for the joints, it's also important to know in the extra-articular manifestation that uveitis is also not a feature of rheumatoid arthritis. Let's look at another case, a 50-year-old male who has rheumatoid arthritis for about 6 years duration now, and presents to you with cough and shortness of breath, which has gradually progressed over a period of 6 months, and denies any history of fever, weight loss, no leg swelling. We have examined the patient, there is no lymphadenopathy. And then a chest X-ray is asked for, which shows bilateral basal reticular shadows. And then in today's world, one progresses and asks for a CT scan, and you can see that there is honeycombing, which is very typical of the usual interstitial pneumonia pattern that we see in rheumatoid arthritis. Of course, you can also have the non-specific interstitial pneumonia pattern. And in this CT, of course, I'm sure you can see this very clearly, and that's a rheumatoid nodule. So there are various other manifestations, pulmonary manifestations of rheumatoid, but this is clinically what we see in practice, very important, the interstitial lung disease, and of course, pleural effusions and organizing pneumonia, bronchiectasis, the rheumatoid nodules, as I mentioned, Kaplan syndrome, which is pneumoconiosis with rheumatoid arthritis on exposure to silica, follicular bronchiolitis. So these are all the other manifestations, the pulmonary manifestations, which one has to remember. And the other spectrum, now moving on from the lung, is the neurological involvement, with sometimes patients present with mononeuritis multiplex. And this particular patient also has ulcer over the leg bilaterally. And that is where when you start thinking about the process of rheumatoid vasculitis, where the B cells start dominating, and then there is involvement of the vascular bed. And you can see the ulcers here. This is, of course, just to show that there is a deforming arthritis already existing in this patient. And then this can come with vasculitic manifestation. And this is different from the general atherosclerosis, which also increases in patients of rheumatoid and is responsible for the cardiovascular events. But I have put it up there just to emphasize the vascular manifestations of rheumatoid. Again, to emphasize that one has to look at rheumatoid as a systemic disease, a rheumatoid disease, That's why it's with physicians, and one has to do the best to take care of the joints as well as the systemic manifestations. We talked about the rheumatoid nodule, very typical. You can see here a very nice rheumatoid nodule. Typically occurs in the subcutaneous tissue of the forearm, the elbows, and the lumbosacral area. And microscopically, there is a central fibrinoid necrosis that is seen, and it may resemble necrotizing granulomas and sometimes be very confusing. In fact, I recently saw a very interesting case where the patient had interstitial lung disease, no joint manifestation, and was referred because there was rheumatoid factor positivity to say whether this is rheumatoid arthritis related lung disease because there is no joint involvement. And thankfully, this patient has very classical bilateral subcutaneous nodules at the elbow, which helps me to establish the diagnosis that this patient has come with a dominant extra-articular manifestation of the disease. So just to complete the list of extra-articular manifestations, atlantoaxial subluxation, mononeuritis we talked about. Pericarditis is one manifestation which I recently saw in one of our male patients of rheumatoid. Kidneys, compared to the connective tissue disease spectrum where we talk so much about the kidney, it's not a common involvement. So if the kidney is involved, it's usually either the toxicity of the drug, particularly NSAIDs, or you're looking at a long-standing inflammation with resultant amyloidosis as a manifestation of renal involvement. And of course, patients often come with fever, fatigue, weight loss, and hematological manifestation of Felty syndrome, and the complication of lymphoma has to be kept in mind. So maybe if we have another 5 to 10 minutes before I leave it for the questions, we have 2 cases more to go. So I want you to look at these hands carefully. And this is a patient who has an early morning stiffness of 10 minutes, very slowly progressive deformity at the hand joints. And when you examine it, you'll feel a bony swelling. It's not the same soft synovial boggy swelling. And this has to be kept in mind because this is not rheumatoid arthritis. So this is primary osteoarthritis of the hands, and you can clearly see that there is DIP joint involvement dominantly, some involvement of PIP, but absolutely no involvement of the FCP or the wrist joint. So if you see something like this, then one has to keep in mind that this is a primary osteoarthritis of the hands and not label this wrongly as rheumatoid arthritis. And again, revisiting what is not rheumatoid. So you look at the nails here, you look at the single fusiform swelling of the finger. This is not seen in rheumatoid, so this is classical for psoriatic arthritis. You look at this kind of diffuse swelling over the forearm, tenosynovial involvement. Think about infections, tuberculosis, Hansen's. They all will present with joint pain, swelling. And so it's important that not everything that is involving the hand joints has to be put in the basket of rheumatoid, and one has to be careful with these differentials so as to not miss them. And these are some of the subtle points which will help you make the differentials. So with this clinical picture, the last 5 minutes I'll spend on the classification criteria and the diagnosis. And I'll skip these slides, which initially I thought I would want to cover, but then we'll be skipping this. This one slide tells you that the basic investigations that we do as clinicians to make a diagnosis supporting the clinical diagnosis of rheumatoid arthritis. These are the X-rays which you can appreciate the amount of joint destruction that happens and how the joint space completely narrows down and the joint gets destroyed. And this can be picked up early on an MRI or an ultrasound also, which you will be shown in the next session on rheumatoid arthritis. So we all talk about making a diagnosis very early in RA, and although said easily, it's not something which can be done very easily because it still remains a little bit challenging, particularly when it comes with limited clinical presentations, and there are differentials to be kept in mind. And there are often limitation of the diagnostic markers because remember, In early presentation of the disease, a rheumatoid factor anti-CCP can be negative, X-rays can be normal, even your ESR CRPs can be normal. So we have read this in the past, the classification criteria. Now this is an old criteria, 1987 criteria, but I still put it up because it helps you to understand that how we have evolved in terms of the classification criteria. Now you see in 5, 6, 7, rheumatoid nodules, positive rheumatoid factor, radiographic changes. Now these were difficult. They were present only in long-standing cases, sometimes particularly the nodules and the radiographic changes. And therefore, in 2010, we had the new classification criteria. Important to know for all the students is that classification criteria are meant for a homogeneous population for a study, and they are not meant for diagnosis in the clinic. They help you, but then there are not diagnostic criteria. We have many illnesses where we have diagnostic criteria. Here we are talking about classification criteria. So a clinical diagnosis is always to be established by the clinician, and there can be many more aspects to it rather than just the formal criteria. But this is there in Harrison. This is important for all of you to know. So we look at the new classification criteria, the joint distribution, the serology, the symptom duration, and the acute phase reaction are the 4 domains that one has to know. When it comes to the joint, if it's a large joint, no points, 2 to 10, 1 to 3. As the number of small joints increases, you can see the number of scores increase. More the number of joints, the score increases. In your serology, if both the RF and anti-CCP are negative, no points. If both are positive, 3 points. Symptom duration, very important. Many times acute viral illnesses will look like rheumatoid arthritis, but they often don't last beyond 6 weeks. And that's why that cutoff more than 6 weeks gets a point. And as I mentioned, acute phase reactants, if they are abnormal, one gets a point. And therefore, if there is more than 6 in total, then one can call it a definite RA from the classification criteria point of view. And if it is less than 6, patient might still fulfill the criteria, remember, prospectively over time. Somebody may come with few joints and then over the next 2, 3 months evolve and have many more joints involved. And retrospectively, if all the 4 domains have been looked at carefully in the records, then still one can go behind and see that whether this patient had these events, and one can actually satisfy this classification criteria. But in practice, if any patient has more than 3 inflamed joints with symptoms lasting more than 6 weeks, there is pain, swelling, and early morning stiffness, which has lasted for more than 45 minutes to 1 hour, particularly involving the small joints of the hands and feet. You have got the MCP squeeze positive, or you have got the synovitis on examination, the symmetry of joint involvement, the inflammatory markers are raised. I think this is good enough for you to make a clinical diagnosis of rheumatoid arthritis. There are atypical presentations, which of course, as you evolve in the practice of rheumatology, you're able to pick this up. The palindromic, where the joints get involved only for 2-3 days, and then it shifts to another joint. So that's a shifting variant of rheumatoid arthritis. And very rarely it can come with monoarthritis, but I would not give that message. Monoarthritis, always think about an infection. So with this, I think I will conclude here. We will just talk about this take-home messages. I think we have understood that rheumatoid arthritis is an inflammatory, symmetrical, erosive arthritis. I emphasized on the component of the pathogenesis, and I think it's important for you to read, simplify it, understand the key elements that are involved, because that will help you with the manifestations as well as the treatment. Early RA manifestations are different, best to pick up at that time. Established RA, you will be able to see the joints, more visible swelling, some deformities, and of course in late RA, be ready to pick up those deformities which we just went through. Extraarticular features, again emphasizing that rheumatoid is a systemic disease. The diagnosis remains clinical. Keep the differentials in mind. Laboratory and radiology support you. Remember, rheumatoid factor can be false positive. X-rays may not give you the true clinical picture, so they are always support you. The diagnosis is never established the other way around based on serology. And early clinical diagnosis is very important now because we have so much happening in the field of rheumatology, so many treatment. But remember, if the patient does not get a diagnosis and is not referred appropriately, then all this newer treatment and newer therapies are never going to be giving to the patient. The patient will never be able to utilize them. So early clinical diagnosis and early treatment is the best way now to move forward in the field of rheumatoid arthritis. So thank you all for your patient listening, and I'm happy to take any questions, or if anything that I have missed, I'll be able to answer.
Thank you, Dr. Sunil. Wonderful presentation. Sunil, there's a request. The etiopathogenesis, which you in the end summarized in a one line, and just put it that on the group for the students. It would be nice.
Okay. The etiopathogenesis
later on, you can just put it on the So, because it's very essential to understand the pathogenesis from the treatment point of view. When you go to the treatment, which molecule works at what level, it will help you in that.
Sure.
Can you throw some light on palindromic rheumatoid and seronegative arthritis?
Yeah. So, palindromic rheumatoid, as I mentioned towards the end, that many times in early phases of rheumatoid, you get the manifestations which are happening only at a particular joint, and they last only for 48 to 72 hours. And the patient will typically come with pain, redness. There is mild redness over the area of involved joint, and there is restriction of the movement of the joint. And then the patient says that in 48 to 72 hours, this completely normalizes and comes back to normal movement. And this can also happen slightly away from the joints also. So this is important because when you listen to the patient, then you can make a diagnosis of palindromic rheumatism, because at the time of presentation, the patient may not have any findings. And these patients are often anti-CCP positive, and that helps in making the diagnosis. And seronegative arthritis, as I mentioned in the laboratory part, remember that once you have established a clinical diagnosis of RA and the patient comes back with rheumatoid factor and anti-CCP negative, one does not close the diagnosis and say, no, this is not rheumatoid arthritis, because 30 to 40% of the patients can be still negative for rheumatoid factor and anti-CCP. So that is seronegative rheumatoid arthritis. You still can take support from your acute phase reactants and your imaging to back up your clinical diagnosis, but it still remains rheumatoid arthritis. Obviously, keep in mind the other differentials.
On the other hand, it can also happen when the anti-CCP is strongly positive and patient is asymptomatic.
Yes. So
should we treat such a patient? What do we do?
Right. So the important thing is, if you again go back to the pathogenesis and we see that you have, say, for example, the citrullinated protein and the T cell B cell interaction has happened, and the B cells have actually produced the antibodies, and the citrullination has also produced the antibodies. But from there onwards, the release of cytokines and the manifestation, it's a completely different process, and it can take a second hit or a variable period of time. It can take up to 10 years, 15 years for the antibody to actually manifest as a disease, and it may not even manifest. And therefore, if you have seen a patient who is anti-CCP positive, there is no palindromic pains, there is no joint involvement, then one would observe the patient and not treat the patient just on the basis of a positive serology, even though you know that it's a 95% specific test, but the joint manifestation has to be there, or an extra-articular obvious manifestation has to be there to initiate treatment.
So I think that is very important for the students to know that every anti-CCP positive patient need not be put on disease-modifying anti-rheumatoid. So rheumatoid arthritis per se is a clinical diagnosis. Investigations are just to support your clinical findings. I think there is one more question.
Yeah, so the question in the chat box I can see is very similar to what you just asked, that if serology is negative, RA and CCP, our symptomatically is similar to RA, Should we go for treatment of RA or consider other possibilities? So you have answered it almost everything in the question itself. Consider other possibilities, and you can still make a diagnosis of seronegative rheumatoid arthritis and treat the patient. But consider other possibilities is an important thing to be underlined there.
There's one more question. Can DMARDs be started in a chronically deformed joint? For example, a patient is having swan neck deformity, and will it respond to treatment?
Okay, so that's an important question. So deformities are resulted from the altered biomechanics of the joint, which have resulted from damage to the structure. And unfortunately, all the best therapies, including the biological DMARDs that we have, can only reverse the synovial inflammation. But once the damage has happened, then the reversibility with the help of medications is no longer there. One can, of course, still treat the rheumatoid for any other joint which is swollen or there is any inflammation. But per se, for that deformity alone, it might not help. If there is some inflammation there, then there will be some reversibility, but no complete reversibility. So you treat, you take help of the physiotherapy, strengthen the muscles. And if it's a very bad deformity and the patient is very keen for a single hand joint, single finger repair, then one can even consider a surgical exploration for that.
Then ultrasound help to find out whether the disease is active?
Yeah.
A musculoskeletal ultrasound?
Correct. So what I skipped through the slides was one of the, I don't know if my slides are still visible to you, but as I answer, maybe they are not available right now. So yes, ultrasound can help you pick up inflammation, particularly 2-3 things. The synovial inflammation can be picked up very well on ultrasound in the form of a synovial thickening. And then there is something called as a power Doppler, which is done by the ultrasound department, and power Doppler signals can help you pick up the flow and the angiogenesis that is happening there, which is predictive of the inflammation. And of course, it can also help in picking up the erosions early. So if you talk about the activity, the synovial swelling with evidence of power Doppler signals is what helps you to pick up the disease activity.
Next question is, how much time should a patient be treated with conventional DMARDs before labeling it a DMARDs failure? I think this question will take with the treatment session.
Yeah, I think yes. I can see that, there's a lot of questions pouring on the side of this thing. From this particular talk, I think all the clinical questions, if there are any other clinical questions, I'm happy to answer. Anything anybody wants to share or seen in some clinic, and it's very important.
How often do you see ILD coming as, patient asymptomatic musculoskeletal bias and coming only with ILD and an anti-CCP positive?
Yeah, so 5 to 10% is what sometimes you can develop. You can have patients who have, most of the time, the interstitial lung disease is a late manifestation, but in about 5 to 10% of the cases, ILD could be the manifestation, and then you have rheumatoid factor and anti-CCP positive and no joint involvement, which is now also called as interstitial pneumonitis with autoimmune features. And like the case that I discussed, wherein, I just had subcutaneous nodules as an additional thing, but then one starts treating this as an interstitial lung disease along the line of rheumatoid arthritis.
There's one clinical question, how to differentiate between episcleritis and scleritis?
Okay.
Also the difference in approach to management.
Yes, so episcleritis is usually patient presents with a lot of redness in the eye, but then it's not painful. And with scleritis, there is a deep boring pain. Scleritis is extremely painful, and as you know that it's the layer below. And differentiation is very easily done apart from this clinical thing and the examination, wherein you will get a very tenderness which can be elicited by just keeping your thumb over the eye of the patient, and your ophthalmologist will be easily able to differentiate it with the installation where the capillaries in episcleritis will just blanch out, and it doesn't happen. The superficial capillaries doesn't happen with scleritis. So that's how you differentiate clinically as well as with the opthal between episcleritis and scleritis. Recurrent episcleritis also warrants treatment, but many times it can be observed. But scleritis is often an indicator of vasculitic process, and it has more propensity for complications, and therefore one would treat it more aggressively.
Thank you, Dr. Singh. Any more questions? Okay, there's a request to everybody. Please join in by 11 a.m. sharp. Okay, we would like to prefer to start at 11 dot, so that we finish in time. It's a Sunday. Everybody wants to spend time with family. And thank you, everybody. Thank you, Dr. Sunil. It was a very nice presentation. Whenever you get time, just put that E2 pathogenesis in for the students.
Sure,
Thank you so much.
I'll do it straight away. Otherwise, I'll forget.
Okay. Thank you.
Okay.
And we have our next session on 9th April, where we'll have Dr. Smriti taking us through the treatment aspect of rheumatoid arthritis. And we expect more PA students to join. This is basically only for the students. And it will be nice if more and more students join. You know, we all are basically hardcore teachers, and we would have love to have more students on the joining the group. Okay. Thank you. Thank you so much.
Yeah.
Thank you, Dr. Sunil. Excellent.
Thank you. Thank you.